morning, everybody. Welcome to Pediatric Grand Rounds. Thanks for those of you who are online, just the usual reminders. Make sure you're muted and your camera's off. And if you have questions for any of our speakers, go ahead and put them in the chat whenever you feel ready, and I will ask them at the end of the presentation. And I get to turn things over today to Dr. Lori Ruttman to introduce our lectureship and our scholars. Thanks so much.
Thanks for the invitation to present today. So my name is Lori Ruttman, and I'm faculty in the Division of Pediatric Emergency Medicine. I'm also Program Director for the Quality Improvement Scholars Program, which is the capacity that I'm here to speak to you today. Today I'm going to give a brief overview of the QI Scholars Program, and then I'm going to introduce the 2022-2023 scholars. Each is going to present the project that they've been working on as a part of their program participation. And then we should have about 10 minutes at the end for questions about their projects and also questions just in general about the program. So please hold your questions and comments until then. QI Scholars began way back in 2015, really with the goal of increasing faculty expertise related to the rigorous evaluation of quality improvement activities that were already happening throughout the Department of Pediatrics and really throughout the entire hospital. There are several components to the program. Scholars apply with a QI research project in mind, and then the program provides an advanced QI methods curriculum, mentoring and statistical support, a community of QI leaders from across our health system, and CME credit for physician participants. Our program faculty are listed here. Again, one of the real strengths of this program is the dedicated support that each scholar receives to both maximize their learning and to make their projects a success. When the program begins every October, each scholar is paired with a mentor experienced in QI research methodologies. They meet about twice per month to work on project design, identify the data that's needed to complete their project, and then they work with our faculty data analysts to obtain the data that they need. The mentor and scholar work together to interpret the data analysis that they've received from their statistical team, and eventually they draft and submit a manuscript based on the results. We're really fortunate in this program to have experienced statisticians as part of our program faculty, and each scholar is paired with a statistician and a data analyst with whom they meet regularly as needed. Scholars do have access to their data and statistical team for 1 year after the program completion, knowing that sometimes the project is not quite ready for publication or needs some more modifications a year after the program's done. Our monthly seminar series makes up the program's didactic curriculum on advanced QI research methods. These occur on the Seattle Children's main campus from 9 a.m. to 1 p.m. Seminar attendance is required for our scholars. And currently 4 of the seminars are given by outside speakers from institutions such as Cincinnati Children's Hospital, the Harvard School of Public Health, and Kaiser Permanente Washington Health Research Institute. 8 of the seminars are given by faculty from our UW Department of Pediatrics and also from the University of Washington Medicine faculty. The topics from the 2022 to 2023 cohort are listed here. And every year we really do modify the curriculum based on scholar feedback and learning needs, but this gives you an idea of the topics that our QI scholars are exposed to. After each morning seminar, scholars have lunch and then a 2-hour afternoon session, usually from 1 to 3. The afternoon sessions are comprised of works in progress and facilitated project work time. Scholars present a WIP or work in progress session to all program faculty at least once and ideally twice during their program participation. These presentations serve as excellent opportunities to address project barriers with the larger group and all of our faculty at once. And really active participation and engagement is expected in these sessions. We also recently added a facilitated project work time to the afternoon sessions. These include brief, focused didactics on topics such as writing aim statements, creating key driver diagrams, writing introduction, methods, various parts of a QI manuscript, followed by dedicated project work time. And the intent is really to keep the momentum going on scholars' projects and allow them to really collaborate and learn from each other in the community of scholars in a smaller group setting. QI Scholars is now in its 9th year, and we've reached 13 different subspecialties here at Seattle Children's. They're all listed here. We did recently expand to include scholars who are quality leaders from the Center for Quality and Patient Safety here at Seattle Children's, including improvement advisors, nursing leaders, dyad pairs who are involved in our microsystems or mesosystem teams. And so really to give you an idea of the current state of the program, its growth, and then the projects that scholars are working on, I've included a list of our current class of Seattle Children's scholars here. Beyond the impressive reach of the program within the walls of Seattle Children's, we've also recently expanded to include a cohort of scholars from across UW Medicine. So this inclusion of scholars from across our health system has really added tremendous depth to the community of our program and to really the shared learning across scholars. The current participants from across UW Medicine and their projects are listed here. You will have access to these slides, so you don't have to read them all now. So who's eligible to apply? We accept faculty applicants from any department or division at Seattle Children's Hospital. We estimate that the program requires approximately 5% protected time, 5% FTE to complete. And this is generously provided by the Department of Pediatrics for the Department of Peds-based scholars who are accepted into the program. Quality leaders who are affiliated with the Center for Quality and Patient Safety, microsystems, or mesosystems are also eligible to apply. Some key dates for the upcoming program cycle, if you're interested in applying. The program announcement and request for applications was just released on April 29th. Applications are due by 5 p.m. on June 28th, and the scholars will be announced by mid-July. The kickoff meeting for the 2024 to 25 cohort will be on October 15th, and the program end date is September 30th of 2025. We do have a site on Child under Research, Centers and Programs, QI Scholars, where you can view all of our current scholars, our program faculty, and see the amazing work that our program alumni have accomplished. And that's also the spot where you can apply to the program. But without further ado, we're here today to hear from our last year's class of scholars. So I'd now like to introduce the scholars from the 2022-2023 class. Unfortunately, Dr. Chris Baresh from the emergency department will be unable to present his work today on improving access to Narcan and Suboxone for children with opiate use in our emergency department. He did recently present this project as a platform presentation at the PAS meeting in Toronto, and he will present again at the Emerging Topics in Quality Improvement noon webinar on Tuesday, June 11th. So if you'd like to hear about Dr. Baresh's impressive work, I encourage you to tune in then. But today, I'm thrilled to welcome Sarah Caulfield from the PBMU, who will discuss her work to take behavioral approaches to managing patients on the PBMU and what that does to the psychiatric milieu on that unit. Following Sarah, Dr. Sarah Mahoney from Hospital Medicine will describe her project to improve care for patients with eating disorders who are hospitalized on acute care. And then finally, Dr. Lauren McDaniel, also from Hospital Medicine, will share her project, which is really aimed at improving overnight sleep for hospitalized patients, a project that she also recently presented at the APA Quality Improvement Conference in Toronto, where it was awarded one of the top 3 best abstracts of the entire meeting. So again, each of them are going to present their project, they'll hand it over to the next scholar, and then we'll hold all questions and comments for the end. Thank you. I'm going to hand it over to Sarah.
Hi, I'm Sarah Caulfield. I've worked on the PBMU for 34 years. And my goal with this project was to attempt to decrease violent restraints on the PBMU through promoting a skills-based behavioral intervention approach. I have no conflicts or disclosures. Somehow my mouse is having a little problem.
Your mouse is being a pointer.
It could do both.
You want to advance that way?
Yeah, I'll just advance that way.
There you go.
Cool. Yeah, I have no disclosures. Okay, the PBMU has 41 beds across 3 units, and we take care of kids aged 5 to 17 who have a variety of pediatric psychiatric diagnoses. The units always had a less restrictive approach, and we currently have no seclusion room. We want to do everything we can to avoid seclusion or restraint with our kids because it's physically very dangerous for both our staff and our patients. Most of our staff injuries occur during restraints, so we want to do everything that we can to avoid that. And it's also psychologically traumatizing both for our staff and very much so for our patients. So the PBMU behavioral philosophy is really such that children develop maladaptive behaviors and problem behaviors because they serve a function. And that to change those behaviors, we have to understand the function and hopefully teach the kid a better skill to meet that same function. Because of this philosophy, over the years, we moved away from behavior management systems that were very tangible, reinforcer-based, which were in place when I was on the unit, to more skills-based approaches. And some of the reasons for that is because, number one, problems with this approach is that kids are often super excited about small prizes and rewards when you first introduce them to them. But after time, they grow tired of them. I'm like, I don't care about that little plastic thing that I'm supposed to be earning. And then parents are like giving us feedback that we cannot do this at home. It doesn't fit into the budget. And it's this ever escalating need to like bring on new toys and stuff. So we really moved away from that. And then the final thing is that inevitably when our kids engage in their maladaptive behaviors and problem behaviors, we have to withhold the rewards, and that often results in an escalation. So we actually thought that we were probably having some escalations related to that behavioral approach. So we moved towards a more skills-based behavioral approach where we taught kids about an escalation cycle. So there's a picture there of the escalation cycle. We taught that several times a day, and we rolled out something called a trigger card, which we later renamed to be calling a coping card. And all the staff carried them in our badges, and we basically taught kids about triggers, what their warning signs were when they start to get upset, what they could do to take care of them, and skills. And we coached that all day long to attempt to avoid escalations and deal with them quickly. And their trigger card then became a template for their safety plan when they went home. Over the years with this philosophy and also with the unit leadership that was really dedicated to avoiding restraint, we decreased our restraint usage and eventually closed the seclusion room that was in our old unit. And then when we built the new unit in 2014, we actually got a waiver from the state to build a seclusion room-free unit, which was pretty innovative. So note, not everyone was happy with this approach. And we did get people complaining that kids run the unit, and there weren't enough consequences for behavior. I will say there is a literature to support other units who have moved away from incentive-based programs and have experienced a decrease in their restraint rates as well. Also, the 6 core strategies for reducing seclusion and restraint, which was published in 2006 by the National Association for State Mental Health Program Directors, specifically calls out strength-based approaches where you teach kids self-regulation, teach them about triggers, and teach them about how to take care of themselves, along with other things such as keeping good data, which we were doing, director-level review of all restraints, which we were doing, and also good debriefing of restraints to learn from each restraint. Okay, so there's a lot of our background. Then what happened was COVID. And during COVID, you can see, and actually just a little bit before COVID, our restraint use started to go up pretty dramatically. And this is total number of unique patients with violent restraint orders placed. So you can see the generally lower use before and then the peak during and then subsequent to the COVID pandemic. So the pandemic had so many impacts on our unit. It's really made it very hard to run a therapeutic milieu. Because of social distancing, we had to totally redesign our group programming. We had to change our groups all around. We couldn't have as many kids in a room. And due to high staff turnover during this time, we lost a lot of our institutional knowledge about teaching and coaching skills. And then we brought on travelers, and travelers didn't have the right credentials to actually teach some of these skills groups. So we ceased teaching a lot of the skills groups. And then also, in an attempt to get kids to wear masks, we instituted a movie reward. So like if at the end of the shift, if you all wore your mask, we'd watch a movie. But that then resulted in a lot of unstructured time with kids watching movies. Then, because of a lot of the long-term placement facilities closed, a lot of our kids with really severe, long-lasting illnesses got stuck on our unit. So we had these really sick kids with like really problematic behaviors, just increasing the acuity of our unit. So in 2020, fall, our PBMU microsystem started. And our aim statement was to reduce the average number of unique patients restrained per month and reduce total monthly restraints and reduce disparities. So our first intervention was a back to basics. It was basically a stabilized intervention, focusing on the interventions that had previously been successful on the unit to decrease restraints, namely running a structured daily schedule. So we did everything we could. We worked with infection prevention to see how can we get back to running a structured daily schedule. We started using more coaching about skills-based strategies, such as emotion coaching and problem solving with kids, all the things that we used to put on their trigger cards. And we went around every day and report shift change, and we coached this and reminded our coaches to it and focused for 2 weeks on each particular back to basics skill. And so during the active intervention phase, we did see some reductions in our restraints. Specifically, and this was called out in our magnet renewal thing, we saw a decrease in per patient day restraints right during the active interventions time, and also unique patients restrained reduced from an average of 20 a month to 15 a month. But overall, during the whole year, we still continued to see an escalation in the total number of restraints. I will also say that we decreased disparities during the time that we did a conscious anti-racism training, but then again, after that finished, we saw disparities pop up again. So we know that's something that we need to continue to focus on. Okay, then next our microsystem, the next year we focused on fidelity to the daily schedule. So we focused again on really leading that structured daily schedule for kids, and we addressed all the barriers that made it hard for coaches to lead that. And then as part of my QI's project work in looking at this data, I found a correlation with each time that we actually followed the schedule with fidelity, our restraints decreased. So the first graph on top is the percentage of time that we're actually running the schedule as according to what it says on the daily schedule for the kids. And then every time we get above 50% or so, our restraints on a monthly basis dipped. So I thought that was pretty notable in terms of the response that kids have to structure, routine, and probably a little bit to the content that we're teaching in the groups. Simultaneously to me starting my QI project, the unit leadership rolled out a new model of care. And this was really great. What we did was we divided the unit into 3 units. One is child, one is adolescent, and one is a biobehavioral unit for kids who are severely impacted by autism. And it's resulted in a lot of improved teamwork and cohesiveness. We built 3 schedules for the 3 programs. The behavioral approach on the new model would be changing to modified PBIS, which is positive behavioral support. This is where our staff were taught principles of giving 5-to-1 positive to negative feedback to kids, catch them being good, and pairing that with stamps that they can turn in for small rewards. Of course, I immediately perked up my ears like, that sounds like an incentive system again. But I will say that this new MPBIS is much less transactional than the old one. It's not about like, do this and I'll give you this. It's like, catch kids being good and give them a stamp. Later, they can turn that in. So this is when I started my QI Scholars Project, and I thought it was a perfect time to measure the effect of also promoting getting back to the coping skills approach in addition to this 5-to-1 feedback approach. There's my key driver, which I'm not going to go into too much detail, but my goals were to reduce the incidence of restraint on the PBMU. And then my key drivers, that was my smart aim. My key drivers were basically we need to get the kids carrying their coping cards again, filled out. We need mental health therapists to help us get them filled out because they know where the kids' lagging skills and deficits are and what we should be teaching them. And getting staff to use the coping cards. So kids carried these coping cards. We moved them into the guidebook that they carried, which was part of the new model of care. And then also, consistent with both approaches, I helped build out the schedule for all 3 programs. So Alicia Thompson, our clinical director, advocated and got all kinds of support from art therapy, music therapy. We got dog teams back involved, and we built in a very much enriched schedule. And I helped with the logistics, all that, and building a schedule for kids that was appropriate in terms of like fun times, a little bit of demand, and then going to the patio and having meals. So we tried to build back the structure. And then the other intervention was to ensure that coaches were giving 5-to-1 positive to negative feedback and stamps, and hopefully making sure that kids had their coping plans filled out. So those are 2 little pages you see in their guidebook that the kids carry with them. One is the coping plan book, and they're supposed to fill that out with their mental health therapist, who knows best what they should be working on. And then that next one is the stamp page, where we give stamps when we catch them being good. During the rollout, we had super users who went around and observed and coached and tried to get us following each behavioral plan with fidelity. So we took fidelity checks from March 7th through September 2023. During the rollout of the model of care, we had super users. The fidelity check was on a paper form. We observed each group for 10 minutes. We had to know who the kids were and get their medical record numbers there, and then counted what kind of feedback did they get. What did they get, the 5-to-1 positive to negative? And then we checked to see if they had their coping plan filled out in their book. And then we uploaded the forms to REDCap. Most of the fidelity checks were done early on in the rollout when we had super users. Later, we planned that managers would come around and give coaching to staff and try to get fidelity to our program. So some of the initial results and analysis, there were a total of 699 fidelity checks from March through September. The coping plan, my piece of it, I did not get added to the fidelity check until June, so really I could only do a comparison or look at that strategy from June on. Some of the red cap entries had wrong dates, so I had to do some cleanup. I finished cleaning up in March, and I'm currently waiting for my data pull. We had much more fidelity to 5-to-1 positive feedback when we had super users out there coaching. Very few of the patients had coping plans filled out in their guidebooks. So I think it's really, we're really struggling to get back to that sort of skills, strength-based coaching. And fidelity checks were really hard to complete because they are time intensive. You have to go, you have to know who all the kids are that you're observing. So it takes the familiarity with our population, and it takes a lot of time. So some updated restraint data that we saw during this time. So initially, right after the March 7 rollout of our new model care, we had a slight decrease in our total number of unique patients restrained, and then restraints popped up again. And we know there's some contributors to that. First of all, before the rollout, we had decreased our census so that we could train all of our staff. So having fewer patients on the unit just helps us with acuity because there's more space for when there's not crowding. So after the rollout, we immediately began a needed remodel of our fire suppression system. And so we kept having to close areas of the units while we maintained the census, and there was more crowding. And there was also constantly change in construction going on. So that was a variable. Then churn and turn was going on, and I don't understand it very well because I'm not a manager, but basically, at any given time, about 60% of the staff on the floor are brand new, orienting, and they don't have the philosophy or the experience. So that was a major barrier. But I would say that the biggest impact on our restraint rates was that we made a complete change in the model of care to our biobehavioral unit. So previously, these kids who were severely impacted by autism, we didn't know how to work with them very well, and they tended to have very little demands on them and spend a lot of time alone in their rooms without too much structure. And now we have an amazing program director, and we have a lot of structure. We have ABA pull-out sessions and a lot more expectations. We also increase the census, and we're working intensely with these kids. So because they're nonverbal, they need a lot of physical redirection, and they get a lot of restraints. So the actual per patient day restraint rates for these kids is about twice what it is on the NU unit. And I can say unequivocally that their care is dramatically better. But that really pushed up our restraint rates. So there's a lot of factors. So lessons learned, the context and impact of many things that we can't control impact. Logistics and coordination are so important on a psych unit. I was humbled by the complexity of our data. Alicia Thompson, our clinical director, she has improved our data so dramatically. You can look at it so many different ways, and I'm only beginning to appreciate that. And I now feel like it's really my responsibility to understand that data, so that was a great lesson learned for me. My next steps, I'm waiting for a data pull. Program-specific managers now have been assigned, so they're going to go around and really coach to fidelity in the different programs, so we can continue to try to build fidelity. We're building out the daily schedule. Alicia has advocated and gotten resource for a new occupational therapist for the unit, which is great, and a recreational therapist, which I'm ecstatic about. Our kids need rec therapy so badly. And so we're just building out that schedule. And there's some coach-led group work done and a PMHS residency to support coach development of skills coaching. And I just want to say thank you to Maureen O'Brien and Alicia Thompson for their support in me being part of this. And then for the QI Scholars, Lori, for like an amazing year of sessions. It was really wonderful. Karen Yonakawa, my mentor, who helped me a lot. Andrea for all the logistics and meals and making everything work. And my peers, they're really inspiring. So it was a great experience for me. Thank you.
Sarah and I work together a lot. She definitely knows who I am. And her talk segues, I think, really well into mine. So you just heard a little bit about how COVID affected the PBM milieu, and one patient population that it really affected are the eating disorder patients. Their care transitioned from partially the medical floor and then the PBMU to just the medical floor, and our length of stay went up pretty dramatically. And we had some hypotheses about that. One was potentially that we were doing something different in terms of the care, especially supervision, and the other was that a lot of the aftercare options had also changed quite a bit. And so my project focuses a lot on the care we provide in the hospital. I don't have any disclosures. And so what does this look like? So the refeeding pathway is specifically for eating disorder patients who are really sick, who need medical stabilization, and are at risk of something called refeeding syndrome, where they can have really, really severe drops in their electrolytes when they start to eat an adequate amount of food. And when you have an eating disorder, this is really uncomfortable physically and psychologically. But it sounds really simple on the surface. Food is the medicine they need, and these patients often will need like an NG tube to get their nutrition. And the therapy part is exposure. Now, on the medical unit, this is a very nice looking room over here in the photo, but the patient is basically eating alone. And if you have an eating disorder, that's basically asking somebody to do the impossible. The therapy modality is something called meal support therapy. This is an evidence-based therapy that's been around for a long time, and this is a facilitated mealtime with an adult who is trained basically to coach the patient through the meal and actually model eating. So it's usually someone eating with them, and it just provides repeat exposure, reassurance, and decreasing the anxiety of eating the meal. And this is really important because it's integral to family-based therapy. So if the patient is discharging home, this is what they would be doing at home. Or if they have to go to a residential facility after Seattle Children's, this would be what the parent is doing later. So my project from June to September is a CNA-supported virtual meal support. So we originally had a virtual meal support program that got very low engagement. The patients just did not want to be on screen. It was really well structured. It had all of these classes they could take virtually, and our login rate was really, really low, like less than 20%, despite lots of going around and coaching them and asking them to log on. And so the goal of this project was to do a phased support. So they would have one-on-one support for a short period of time, and then we would peel back that support one-on-one, moving closer and closer to just virtual support throughout the project. So the CNAs were going to bring the meals. They were going to help the patient connect to the virtual meal support that was run by a more expert provider called a Recovery Ally. They were going to observe the meal, and they documented everything that they saw in terms of eating disorder behaviors. And then the Recovery Ally was virtually in one room on a computer talking to a group milieu of patients. And the goal was to decrease the CNA staffing progressively. And then they would also provide coaching to families throughout the process. So the entire medical unit CNA pool and the float pool was trained with a 4-hour training using both video modules and in-person training to coach them on A, what to look for in terms of eating disorder behaviors, and 2, how to document them. And then also a set group of ways to coach. Based on scope, CNAs cannot technically coach with new content that they make up, but they can provide coaching that has been taught to them, which is an interesting thing that I didn't completely understand going into this. So the outcomes. We had some good and some not so good. So we saw for the patients who were able to participate, improved weight trajectories. There were decreased length of stay for the patients who were able to participate in the program. And then the documentation that the CNAs were doing gave us a lot better insight for the provider team into disease severity. Now, some families loved it and thought it was the best thing ever. And other families really didn't like it and felt like it was extremely intrusive. And that led to, down here, some CNAs experience burnout. The ones who were burnt out were the ones where the parents were saying, why are you even in here? The bigger problems had to do with staffing this. So getting this patient population fluxes a lot, anywhere from 2 patients to 15 patients. And so to get enough CNAs to adequately staff this was really, really difficult. Even across the house, we were having trouble hiring CNAs. And this intervention was too costly to maintain, specifically the Recovery Allies. We lost that position. So 100% of providers have greater insight into disease severity. So this is what really allowed us to, this documentation allowed us to work with families and say, hey, your child is potentially able to do this at home versus they may need a residential facility, and that really, really helped. Here's a run chart of our data. So this is length of stay across for all eating disorder patients. This is the beginning of our intervention in June. This is the end of our intervention at the beginning of September. This is where we started to see a staffing constraint. And so I've broken it out. There were 8 patients who were able to, for their entire length of stay, participate in the program. And their mean length of stay was 10.3 days, which is significantly shorter than before the intervention. And then those 8 were part of a total of 21 who either had intermittent participation in the program because of CNA staffing issues, or who were on other units. So this was only on RC4, and so if you happen to be admitted to, say, RB8, you did not receive the intervention. And so even during that period of time, the difference between intervention and no intervention was over 3 days. And then we did move to something called a medical stabilization model on 9/1, and there is some potential that we see a little bit of improvement after that, but it's a little unclear exactly what's going on there. And for the patients who participated, this was clear across the board that basically the minute that we put direct supervision in the room, their weight trajectories increased. Just to give you some examples. So the ongoing work, as we transition to medical stabilization, one of the most important parts, I think, was the parent feedback that some people loved it and some people didn't. And so we thought, okay, from a staffing standpoint, why don't we engage the parents who want to do this on their own? And so we're using app-based scheduling, a program called Inside Out. So the families who say, yeah, I could be here for every meal, every snack, I want to learn how to do this therapy intervention, they're going to be doing it. And then for the families who say, especially from an equity standpoint, hey, I have to work, I can't be here, I can't do this, then they're able to put into a calendar, and then we can potentially pull a CNA for support times when a caregiver isn't available. We've also thought about, from a supervision standpoint, using cameras, especially at night, where we would only need one staff person then, just to see if patients are getting out of bed. And then we've also, and this is really hard from a space constraint, but group meals would also require fewer staff. You'd only need one person. So if we were able to see on our calendar that multiple families can't attend, that's an option. And then the other thing is for the patients who are showing that great weight gain with one-on-one support and need ongoing support, a partial hospitalization program would allow them to discharge, not be in a hospital bed, but still receive a really high level of care. And that's a program that's been designed and would need a rollout. I also had a great experience this year. I want to thank everybody as well, particularly Olivia Kerwin, who's down in the ED. She was part of my dyad in this work and really helped this roll out onto the medical unit. I'm going to pass it off to Lauren. This awesome project has changed my practice, so I'm excited for her to tell you about it.
So it may or may not come as a surprise that we interrupt the sleep of hospitalized children frequently, and we often do so of unclear necessity, particularly as it relates to the routine measurement of every 4 hours vital signs on all patients, regardless of their illness severity or their acuity. So our goal with this project was to target unnecessary vital sign measurements, and we were looking at all vital signs, but then also specifically focusing in on blood pressure. And the reason we wanted to focus in on blood pressure is it's arguably the most disruptive vital sign to sleep in that it requires physical manipulation of the patient, but it's also the one we most commonly measure inaccurately and thus end up ignoring. So our specific aims for this project were to increase the proportion of patient nights with fewer than 2 vital sign measurements. And the reason we picked two is when you think about how vital signs are measured overnight, they're typically grouped into the midnight and the 4 a.m. checks. So our outcome measures were focused on measurements. And so when we talk about all vital sign measurements, we're talking about, it's including blood pressure, but we're also including heart rate, temperature, pulse oximetry, as well as respiratory rate. And we counted all measurements within a 30-minute period as one measurement. So if all vital signs all 5 of them were measured at midnight, that counted as one measurement. And then if a temperature was measured at 1 a.m., that would be a second measurement. So recognizing that there are both intentional and unintentional reasons why we may measure vital signs more or less frequently than what would be ordered, we looked at the ordered frequency of vital signs as our process measures. And then for our balancing measures, we looked at markers of clinical deterioration. And then we also looked at continuous pulse oximetry use, because what we didn't want to happen is we were measuring vital signs less frequently overnight and then replacing that with pulse oximetry. Because when you think about the alarms, it's arguably potentially even more disruptive to sleep. So we targeted hospital medicine patients and patients that were physically admitted to the acute care units, but otherwise included patients of all ages, all diagnoses. And we specifically wanted to exclude potentially unstable patients. So for that reason, we excluded nights where there was a rapid response or there had been a rapid response within the preceding 24 hours. We also excluded the first night of admission if the patient was admitted to the acute care unit in the nighttime hours. So the first intervention we did, which is not shown here, is we added a question to the rounding checklist, specifically targeting overnight interruptions. And so there could be a discussion every day on rounds about what was the appropriate vital sign frequency for that patient. And then we made a change to as you can see here, the general medicine admission order set. So all that we did here is we added a hard stop. So this used to, for the vital signs, default to per unit protocol. So now providers, when they're placing their admission orders, reflected on, for at least the next 24 hours, what's the appropriate frequency of vital signs for my patient that I'm admitting. We made several changes to the vital sign order itself. So I mentioned that we removed the default for per unit protocol. When we talked to ordering providers and asked, what does per unit protocol mean? Many did not know. It means every 4 hours on all acute care units. We also removed, we added an every 8-hour and every 12-hour option and removed the every shift option. And the reason we did that is when you asked ordering providers what every shift meant, they told you every 12 hours. If you asked nurses and CNAs what every shift meant, they said it depended on the length of their shift, which could be every 8 or every 12 hours. And then most importantly, what we did is we made it easier. If you wanted to defer vital signs, all of them, or you wanted to defer blood pressure during the nighttime hours, with a single click, you could do that now within the order. So for the analysis of our outcome and process measures, we use statistical process control charting. So when we define special cause as 8 points above or below the center line when we were making decisions on where to shift our center line. So what we're looking at here is our outcome measure. So this is measurements, and we're looking only at blood pressure right now. We're looking at the proportion of patients with fewer than 2 overnight blood pressure measurements. So up is good. You can see we started at a baseline of 37% of our patients having fewer than 2 overnight blood pressure measurements. And then interestingly, and we saw this with all of our outcome and process measures, we saw special cause before the start of our formal interventions, but after we had done a lot of talking about the project with frontline providers and had started having a lot of our key stakeholder discussions. So at that point, we increased to 49%, and this is really our intervention period reflected here. And at the end of our intervention period, we again saw special cause, again to 69%. So overall, this reflected a 32% increase in the proportion of patients with fewer than 2 overnight blood pressure measurements. So this is now looking at our process measure, again still for blood pressure, and it's our process measure, so we're looking at orders. And this is looking at the proportion of patients with sleep-promoting, non-every 4-hour blood pressure orders. So we started with a baseline of 12% of patients with a non-every 4-hour blood pressure order. Again, in that similar place before our formal intervention period, we saw an increase to 28%. And then again, at the end of our intervention period, saw an increase in the orders to 58%. So overall, this reflected a 46% increase in sleep-promoting blood pressure orders. So now switching to any vital sign. So we're back to our outcome measure looking at measurements. And here we're looking at the proportion of patients with fewer than 2 overnight vital sign measurements. We started with a baseline of 11%. In that same location, we saw special cause to 19%, which was maintained throughout our intervention period and then our early follow-up period. And then about midway through our follow-up period in mid-November, we did see special cause back to our baseline to 12%. Looking at the process measure, we started with this is orders for sleep-promoting vital signs. We started with a baseline of 12%. We saw special cause to 28%, which again was maintained through the intervention and early follow-up period. And then in the same place we saw for the outcome measure in mid-November, we saw regression back toward baseline, although we did maintain an overall increase from baseline of 8% of patients having sleep-promoting vital sign orders. So looking at our balancing measures, we saw actually a statistically significant decrease in rapid response, although I think you could argue whether or not that's clinically significant. We saw no change in our ICU transfers pre versus post intervention, and then saw a small increase in the use of continuous pulse oximetry. So there are a number of limitations. Obviously, this is a single center limited to hospital medicine, so some limits to generalizability. And when we recognize we're using vital sign measurements as a proxy for room entries and sleep disruptions, although there are other studies that have made that link between room entries and vital sign measurements as well as sleep disruptions. And really by using measurements, we were able to have a much broader inclusion population and affect more patients. And then something that we're looking into a little bit more with our data currently is a potential for some subtle seasonal variability. And related to looking at our balancing measures with time series analyses, particularly the continuous pulse oximetry balancing measure. So with respect to our original aims, we did see that iterative interventions resulted in a sustained increase in patient nights with fewer than 2 blood pressure measurements, overall reflecting a 32% increase. We saw initial improvement in all vital sign measurements, but once our intervention period concluded, there was a regression toward baseline. I'd really like to acknowledge all of the co-authors on this work and the many people that assisted me with this, and most importantly, the QI Scholars Program. And I think now is the time that we're going to come up and do questions, all three of us.
Hi, I'm Delara. I'm one of the third-year pediatric residents. I have a question for kind of the behavioral health, the presentations, the first two, and then for the sleep promoting. I think a lot of what you had discussed with your PBMU interventions and kind of the patients who have disordered eating kind of reflected to me that, like, as on the general medicine team, there is very inconsistent kind of training even on our end on how to deal and help coach even nurses who are helping de-escalate patients with behavioral outbursts, and wondering how we can utilize things like coping. I love the coping card. I need a coping card too for myself probably, but how can we utilize, I mean, not as intensive, like we don't have those resources that we do have in the PBMU, but what resource can we utilize in that model to the general medicine floor? Because there are a lot of patients with those escalations on the medicine floor, and it causes a lot of distress both on the medical team and on the nursing staff and the other support staff. So that's kind of one question I have on that end. And also for the sleep, is there any, did we look at any disparities with patients who had caregivers at the bedside versus not, and whether that had led into buy-in for nurses to keep them monitored or not? Those were my two questions.
Do you want me to start? Or you want to start?
I think so. So it's actually it's a great question, because the first answer is I would call behavioral support, which is BST. I think, though, you bring up a really good point is, well, what am I asking for? Because if you have the knowledge to say, hey, could you sit with this patient and work on a coping card, that's a very different ask than, hey, can you come fix this? Which I think sets the behavioral support team up better. So I think that's a good like, you know, an idea of, hey, could we sit with them and think about what are the interventions that you could bring up that might help?
I agree. I feel like we can fill out, I got mine back in my badge. I think we can fill out a coping card, the BST can, with kids all over the house. That can also, that information can now also be put into Epic in the new behavior plans that we have in Epic, so that if it gets lost, a kid tears it up because they're mad, you can recreate it. And they do disseminate these around the house.
And also for eating disorder patients, every meal is going to be stressful. And so that's, I think, one of the hard things with the staffing, from the staffing standpoint of, it would be great if we had somebody for every patient, but one-to-one is really challenging.
And then for your question for me around parents at the bedside, and I appreciate you asking that because I did want to share this. Didn't have enough time in my presentation, but we did look at equity measures related to differences in vital sign measurements, and we actually did see an increased odds of fewer than 2 overnight vital signs, both pre and post intervention, when English was the language of care, and when race was non-Hispanic white. And the interventions that we did not affect that disparity, either improve or worsen it. And I think it kind of, a hypothesis that I would have related to that is, perhaps are there disparities in either physically being at the bedside or the ability from a cultural or a language perspective to advocate? Does my child really need a blood pressure all night long when they're here for filtering growth? So I think that there's potentially something there. Appreciate that question.
Thanks.
All right. It's Paul Sherrick. I was going to say, as the Chief Quality and Safety Officer here, the rigor, the elegance, and the relevance of these initiatives really brings a tear to my eye. Thank you so much for all the great work, and thanks to Dr. Lori Rutman for leading an incredible program. Let's see, my question is for Sarah. Number one the use of restraints is a very critical outcome measure that we track, and actually is on our quality core measure set, and it's reflected all the way up to the Board of Trustees as a really critical reflection of our overall health of our quality structure and systems. I'm curious on your thoughts about the more global question, or I guess 2 pieces. One is, how do these changes impact, if we know, the actual mental health outcomes of our patients? So specifically, the shift in the model is, how is it impacting our larger mental health outcomes? Because I know it's a very significant shift in the model. And the second piece is maybe as a balancing measure. Did you think about, or did you look at DART or sort of staff safety related events as your restraint usage dropped? Thanks.
That's the second one, we're looking at DART all the time, the days away from work due to injuries. We haven't formally looked at that. Myself, I haven't, but that's something I can definitely look at when I do my data analysis. And yeah, thank you for that idea. And as to the larger mental health, I don't know that I have an answer to that. I think for teaching these skills and seeing kids pick them up and actually use them and modeling that and getting the therapeutic milieu where we're working together and kids are supporting each other and have a shared mental model, that is only a really healthy thing to see happening. So I think nurses like to help kids to manage their own mental health things, and so the more that we can teach and coach and support kids in a strength-based approach, that improves, but I don't have metrics to show that.
Thank you.
Yeah.
Great. Well, thank you all for attending today. If you have any questions about QI Scholars or want to apply, check out our website, or you can email me directly, lori.rutman@seattlechildrens.org. Thank you all.
Thank you.
Thank you. Good job.